So good evening, everyone, and warm welcome to all of you for the today's meeting. So this is meetings that we call it as Wavelength, which is a digital platform which is provided by Samarth Life Sciences for discussing various scientific activities. So before we go ahead, let me introduce myself. My name is Dr. Sanjay Kamble, and I'm heading the medical team here at Samarth Life Sciences. So, before we start the meeting, I welcome you all. I welcome all the delegates who have joined. So, because our show is also live on the YouTube, and also welcome to all my marketing counterparts in the field. So, just to share about the company, Samarthas is a life. Our vision is to be an innovative health care company that adds life to life. And we have a proud heritage, passionately committed to providing innovative and differentiated products. That makes us proud as well as we make India proud because of that. So just share about us, the group can be recognized a long time back with a humble start. However, now it has grown into a big company which exports our products to various countries like South America, UK, Southeast Asian countries, and many African states. So we have our presence in Asian countries, Middle East, Russia, UK, Poland, and Spain, wherein we export more than 2,250 products and to more than 35 countries. So to cater to these requirements, we have plants, two plants in Himachal Pradesh and a R&D center at Bangalore, which manufactures the critical care products, lyophilized anti-cancer formulations, hormonal tablets. And to cater to all of this, we have robust divisions of 10 marketing divisions that cater to various specialties, and Conquest is one of them, which caters to the oncology specialty. So with this brief introduction, I again welcome you all, and it's my privilege to start this digital meeting, which we call it as Wavelength. The agenda is that we have two renowned speakers who would be speaking on the metastatic breast cancer. The first topic would be taken up by Dr. Tushar, and the second topic by Dr. Pratik, wherein we'll be discussing more on the treatment options in metastatic breast cancer and the clinical evidences on palbociclib. And this will be followed by the questions, if any, from the delegates who have been attending this program. So it's my privilege to welcome Dr. Tushar Patil, sir, for the today's program, who is the first speaker for the day. So Dr. Tushar is a consultant medical oncologist and hematologist at Department of Medical Oncology, Sahyadri Hospital, Pune. He is a consultant. His affiliations also include his role as a medical oncologist at Jupiter Hospital, Pune. He was also a visiting consultant at Bharatiya Sanskrit Darshan Trust, assistant professor of medicine at Bharatiya Vidyapit, then Department of Medical Oncology at PD Hinduja Hospital, where he was associated with long back in 2009, and then Department of Medical Oncology at Gujarat Center and Research Institute, Ahmedabad. Sir has also been the investigator in many phase 3 trials, phase 4 trials, as well as registry trials. And sir has good publications which repute, which are published in national and international journals. So welcome, Dr. Tushar, sir. I'll hand over the session to you once I introduce Dr. Pratik, and then we can start. So again, it's my privilege to have Dr. Pratik sir for today's meeting. Sir is a consultant medical oncologist at Jupiter Hospital, Pune, and he's a trained oncologist from Michigan State Cancer University, USA. He's the author of a chapter on second-line therapy in gastric cancer in the world-renowned Gastric Cancer book, which carries his research in GS cancers. He's treated multiple complicated cancers with triple dual malignancies of bone and also bone marrow transplant. He has international accolades in good journals, paper publications in European countries, and members of renowned Cancer Association. Welcome, Dr. Pratik sir. Again, a privilege to have you for today's meeting. So with this, I request Dr. Tushar Patil sir to start with the first topic. And Geeta, you can start sharing the presentation, and over to you, Dr. Tushar Patil.
Yeah, yes.
I'll just stop.
Please share my slides.
Yeah.
Yeah, is it visible?
Yeah, you can make it full screen.
Yeah, it's visible.
I think, yeah. So, good evening, everybody. Today's topic: current treatment options in hormone receptor positive HER2 negative MBC with endocrine therapy and the targeted therapies that we have. Uh, a ever growing problem world over and in India, and the incidence is not going to stop increasing for maybe a decade or two. One of the most common.
Sir, you are on mute. Okay.
Each year, thousands would die because of either disease progression or failure of the treatment. MBC remains virtually incurable. The 5-year survivals are just mere 20 to 25%, a median OS of almost 3.5 years only. Next slide. If you see at the global scenario, 11.7% of the 2.3 million new cases of cancer it's contributing to, and globally the burden may cross almost 2 million by the year 2030. Even in India, next slide. According to the Globocoin data, breast cancer accounted for 13.5% of all cancers cases and almost 10.6% of all deaths. So a big killer and a lot of morbidity associated, especially in the advanced stages. Next slide. Next. So if we look at the historical, what we say as a division or classification of breast cancer, classically ER, PR, HER2 are now being used, though now a lot of other classifications have come with the advent of therapies for HER2 low population and also the genomic profiling of tumors. But yes, for our discussion here, we would stick to three. One is hormone receptor positive, that is they express estrogen receptor, those who are HER2 receptor positive, and those who do not express either of these called as triple negative. Close to 50 to 60% of the breast cancer cases are hormone receptor positive and HER2 negative, more so in the older population, where the incidence may go up to 70 to 75% of them being hormone receptor or endocrine receptor positive. Next slide. The the goals of therapy in this MBC population, of course, would be to reduce the tumor burden and symptoms, also to have fewer side effects and toxicities, and prolong the survival. We have learned that in endocrine sensitive population, usually endocrine therapy is the best option that these patients have, unless they go into something called as visceral crisis or impending visceral crisis, where we may have to resort to chemotherapy, or there are 2 or 3 lines of endocrine therapy failure where no other choices or options remain for these patients. Next slide. So how do we deplete the estrogen? Yes, of course, by making a premenopausal women or postmenopausal, we could, by doing oophorectomy. It could be a surgical oophorectomy. It could be medical ovarian, what we say as suppression by LHRS agonist or antagonist. And of course, for patients who are post menopausal, aromatase inhibitors could be used. Steroidal and non-steroidal both could be used as a endocrine. Next slide. There are also other strategies that directly target the estrogen receptors. Uh, these are selective estrogen receptor modulators like tamoxifen, and of course ER regulators or down regulators, that is fulvestrant, which is a irreversible inhibitor and much more potent than the other available drugs like tamoxifen or anastrozole. Next slide. So the new era has started with the development of cyclin-dependent kinase inhibitors, palbo, and abemaciclib, which has given a new dimension to the treatment and of course added more PFS, more survival for the NBC patients. Usually what we've seen is whenever the patients earlier were put on only drugs like anastrozole or letrozole, the median PFS was close to 6 or 8 months or less than a year. With the addition of cyclin-dependent kinase inhibitors, we do have a median PFS which is ranging in up to 2.5 years, and survival going up to almost 5 years for these patients, 4 to 5 years for these patients. Our center at Sahyadri was the center which did trial for palbociclib in such populations, and we could see that more than half of our patients lived on for more than 3 to 4 years. So that was overwhelming and really a good drug which we could see very well tolerated. The other molecules that we have as an endocrine therapy when these therapies fail is to target the pathways which we have. One of these targets is mTOR pathway. The other targets could be PIK3 pathways or PTEN pathways, which can be targeted with various drugs which are available to us. Next slide. For patients who develop metastatic disease, irrespective of whether they previously had early breast cancer, uh, for the sake of whether these patients would benefit from endocrine therapy or anti-estrogen therapy, the percentage of estrogen, yes, does make a difference. And the more higher the percentage or positivity, the better or more is the benefit with the estrogen receptor modulators or down regulators. For purpose of classification, 0 or less than 1% would be classified as negative. Anything more than 10% would be definitely called as positive. And 1 to 10, 9%, anything above 1% would be called positive, with the chances that they would respond to endocrine manipulation would be a little lesser. Next slide. So how do we manage these patients, HR positive, HER2 negative MBC? Choosing between the endocrine therapy and chemotherapy, consideration for those who received adjuvant endocrine therapy. What was the preferred first line therapy? Is there a resistance to the treatment upfront or there is a delayed resistance? What are the subsequent line options available to us? Is there any later line therapy available? Additional consideration for premenopausal women especially, and there could be other special considerations in terms of tolerance to a particular drug or a patient profile like GI disorders, cardiac issues, so many or comorbidities which could decide our choice of treatment for endocrine therapies. Next slide. So when we choose between endocrine and chemotherapy, as we've discussed earlier, that for HR positive or HER2 negative MBC, endocrine therapy will always be preferable, and chemotherapy will be reserved for refractory endocrine therapy, refractory to endocrine therapy, or a symptomatic visceral disease, visceral impending visceral crisis, or actual visceral crisis the patient is entered into. Chemotherapy as first line only in minority of patients with visceral metastasis. In patients already initiated with chemotherapy and satisfactory response, we after a certain period of time we discontinue the chemotherapy and then switch over to maintenance endocrine therapy. If there is a progression after the second line of endocrine therapy with or without targeted agents, treatment based on prior treatment responses could be taken up. There is no data that combining endocrine therapy with or without targeted with chemotherapy improves any overall survival, and therefore usually the strategy of combining endocrine therapy with chemotherapy is not employed. Next slide. If you look at special considerations where patient profiles and treatments could be seen, women who progress for more than after more than 12 months from the end of the adjuvant treatment, or patients who have taken at least 2 years of adjuvant therapy, and they could be offered first line endocrine therapy or ET in combination with a CDK4/6 inhibitors. Patients who progress within less subsequent endocrine therapy, second line, or a ET with combination with a targeted agent could be offered. Patients who progress on first line endocrine therapy for metastatic disease, a second line endocrine therapy could still be offered. Next slide, we look into these first line and second line endocrine therapies as they come in. Next slide, please. What is the first preferred first line therapy? Next. Women who progress for who have responded for at least 12 months and who progress after 12 months at the end of adjuvant ET, and patients who present with de novo metastatic breast cancer are the ones who would be offered this first line endocrine therapy. Here, the first treatment that we could offer for such patients would be cyclin dependent kinase inhibitors, CDK4 inhibitors with aromatase inhibitor. Premenopausal women must have their ovarian suppression done either medically or surgically so that they can be eligible for an AI-based treatment. Next slide. If we look at the data, the Paloma 2 data of palbociclib, where aromatase inhibitors and palbociclib was used, and that was the basis for the approval, it had fantastic objective response rates of 43% as compared to 29% for the endocrine therapy with AIs alone. There was a clinical benefit rate of close to 85% for such patients. If you see at the overall survival, 53.9 months is the overall survival. reached as compared to 51.2. Of course, we know the side effect profile of this drug. There was some neutropenia which was seen in these patients. For cumulative incidence of neutropenia was as high as 75 to 78%, but clinically significant neutropenia was hardly seen where the patients had any problems because of this neutropenia. So it was probably only a quantitative neutropenia that we saw, and qualitatively the patients would still be very well preserved and they would not get into any severe sepsis or infection related to this neutropenia. The median PFS which was observed here was 24.8 months as compared to only letrozole where it was 14.5 months. There was a nearing 10 months improvement in the progression-free survival. Next slide. The other drug in question, ribociclib, along with aromatase inhibitors, the Mona Lisa 2 trial. Again, if we see, the response rates were close to 43% as compared to only 29%. The survival here went up beyond 5 years, that is 63.9 months as compared to 51.4, which was also seen in the Paloma 2 trial around the same with the available drugs like letrozole or anastrozole. Again, here with ribociclib, the incidence of neutropenia was seen in almost 76%, but there was some transaminitis seen, some QT prolongation seen, and hence this drug comes with a label. What was seen in this was improved efficacy outcomes and manageable toxicities which are observed in the first-line ribociclib use of these patients. Median PFS again ranged in 25 months as compared to 16 months for the letrozole arm. Next slide. The third drug, the Monarch 3. Again here, the AI with abemaciclib in a hormone receptor positive and HER2 negative. As we could see, the objective response rates were as high as 59% as compared to the endocrine only patient population. The side effect which was predominantly seen here was diarrhea and some amount of neutropenia and fatigue. The Monarch 3 PFS was not reached in the Abema arm, and the placebo arm, that is the endocrine letrozole only arm, it was 14.7 months. Again, classically seen with other drugs where we are using a single drug, the PFS is close to around 12 to 14 months. And if we are using CDK4/6 with this anastrozole or letrozole, the PFS doubles and the OS comes to almost up to 5 years. With palbociclib, which was 53 months, and with ribociclib, which was close to more than 60 months of overall survival. Next slide. So how do we choose between the various CDK4/6 inhibitors? Next slide. If we look at the comparative efficacy of palbo, ribo, and abemaciclib, we know clearly that palbociclib did demonstrate a very good PFS, but could not demonstrate a OS benefit as compared to the placebo arm. Probably there could be multiple reasons for this. One is the patient selection population. They were more of endocrine refractory population which was selected over there. And the other trials, the subsequent trials, did learn from the Paloma trials how to choose or how to select the patient population. There was also close to 22 to 25% missing patient data which was seen in the Paloma trial, and hence this missing patient data could also attribute to the lesser OS OS advantage which could not be proven in the Paloma trial. But if we look at the real world data of these drugs, I think all these drugs are doing fantastic, and most of them do have a very good clinical benefit rate, good response rates, PFS which is well over 2 years in all these, and we are seeing in even palbociclib the survivals are closely ranging 4 to 5 years for these patients. Next slide.
Sir, Geeta got disconnected somehow. She's
I
just
see the
joining.
slides.
Yeah. Geeta just got disconnected due to some.
Okay.
She's connected now. She'll just share shortly. Yes, Geeta, I just called you because you got disconnected. The slides have got.
Yeah. Actually, the thing is, that office may there is some network
No,
issue.
no problem. No, you can reshare.
It got disconnected. Yeah, I'm just sharing. Wait.
Yes, sure.
Yes.
Yeah.
Is it visible?
Yes. Correct. It's visible now.
Yeah.
So if we look at the various parameters comparing palbo and comparative efficacy of all these CDK4/6 which are available today, where the PFS and response rates were compared between these. Next slide. For PFS and ORR, results were similar for palbo and riblo. All the grade 3, grade 4 toxicities also were similar. And of course, few toxicities were more in the palbo arm, few toxicities were more in the ribo arm. All of them could be easily managed, and the quality of life was not really very much impaired. The QTC prolongation is the only one where ribociclib did show there was some red flag raised, and hence it comes with a what we say as warning there. Next slide. Next. The slides are not moving. Yes. There's something called as matched adjusted indirect comparison of palbo versus ribo because of the various patient population that they had, because of the various parameters that were very much different in these trials that we took. And probably, as we discussed, that the trials of ribociclib and abemaciclib learned a lot from the Paloma trial, and they did a lot of modifications to choose the best patient population so that the best outcomes could be reached for such patients. Palbo, ribo, and abema in combination with this fulvestrant. This was the study aimed to determine the efficacy of this using match-adjusted indirect treatment comparisons. Next slide. And when this was done, I think all of them paired really the same. There was no difference when the three drugs were compared. Next. Based on the summary level, it was said that the unmatched and adjusted yielded similar OS for palbo plus fulvestrant compared to abema versus fulvestrant. Similar results were observed for matching patients with in the Paloma 3 to eligibility criteria for adjusting for all the cross-trial imbalance. So there can never be a comparison directly because the patient population was quite significantly different in the first Paloma trial as compared to ribo and abemaciclib trials. Also, there was a lot of missing data. So if today there is a comparison made, possibly palbo will be as good as ribo and abema in terms of PFS and in terms of OS2. Next slide. Yes, it's just a comparison. It's showing the same thing. It's the same. So OS also was similar for these. The results of these analysis corroborate the traditional ITC results and suggest that the OS for palbo and fulvestrant would be similar to abema and ribo fulvestrant in patients with hormone receptor positive HER2 negative ABC, which adjust for the cross-trial differences. Furthermore, the differences in the baseline characteristics between the patient population underline the importance of conducting these analyses when drawing comparison between different drugs of the similar class. Next slide. If you look at the various characteristics of these drugs, I think it's mentioned that how it metabolizes and what are the half-life. So typically palbociclib is more than a day of half-life. Ribociclib is around 1.5 days, 32 hours. And abema is a very short-acting drug, 18.5 hours. Abemaciclib also targets various other CDK, CDK 1, 2, 9, and 14 also. The dosing, of course, because of the neutropenia that is seen, will be different. Here it's palbo, it is 125 mg, 21 days on, 7 days off. The level 1 reduction is 100 mg, and this level 2 reduction is 75 mg, beyond which we'll have to stop this drug. For ribociclib, it is usually 600 mg dosages, 21 days on, 7 days off, and the level reduction is 400 mg that is allowed. Abemaciclib is on a continuous dosing module, 150 mg twice a day continuously. For patients who cannot tolerate, then 100 mg twice daily is the dose reduction seen. Myelosuppression seen more with palbo and ribociclib. GI toxicity, a lot of it is seen with abemaciclib. A QT prolongation is seen with ribociclib, and LFT alterations also with ribo and abema. Next slide. So this will be helpful for us to select the patient population who may not be able to tolerate a particular drug when given, and would be useful for such decision making. So there is no AI, one AI which is better. In trial of advanced breast cancer, exemestane and anastrozole resulted in a similar ORR and OS. Pharmacokinetic data does suggest that letrozole is a little more effective than AI. Also, the cardiovascular side effect profile of letrozole is better. Slide. Alternative frontline therapy or options. Next slide. Fulvestrant monotherapy is an alternative option, and the Falcon trial did show that it improved PFS as compared to only anastrozole, 16.6 versus 13.8 months, and better quality of life outcomes. Next slide. Fulvestrant plus CDK4/6, of course, is what is preferred in the second line setting when endocrine failure setting, and the PFS here was 27.9 months as compared to 32.1 months. The difference was not statistically significant. Next slide. Fulvestrant plus anastrozole is an acceptable alternative to AI CDK4/6 combination for patients who present with de novo MBC if they are ET naive. And there was a PFS of 15 versus 14 months, which was seen. OS was 50 versus 42 months. There could be superior outcomes with fulvestrant plus anastrozole than anastrozole alone. Next slide. For patients who have not received any aromatase inhibitors in the adjuvant setting and are unlikely to tolerate a CDK4/6, AI monotherapy also could be appropriate. For patients who've got a very, very small volume of metastatic disease, maybe one or two bone only mets, no other disease anywhere else, then they could be maybe what we say as spared the any advantage. There may not be any major advantage of adding a CDK4/6. They can be controlled only with AIs as such. This is a very small select population. Otherwise, for all, AI with a CDK4/6 combination is the treatment of choice for HR positive, HER2 negative MPs. Next slide. If you look at the resistance pattern, I think PIK3, P10 pathway activation, mTOR pathways are the ones which give rise to resistance for these patients. And classically in the endocrine positive patients, HR positive patients, when these patients become refractory to the treatment or relapse on one particular line of treatment, these are the lines of therapies that we offer. PIK3 analysis, if it's positive, then these patients typically go on alpelisib and fulvestrant combinations. Again, alpelisib is not a very easy drug to tolerate. Hyperglycemia, rash, diarrhea, common side effects with these drugs. Most of these patients would require dose modification and dose reduction. And the second PFS that we get with alpelisib combination may be too short, maybe 6 to 8 months only. So not a very easy drug to handle as such. Next slide. Subsequent line options for patients who progress on adjuvant ET or within 12 months of completion and who progress on first line treatment for metastatic disease. Next slide. So this is just what we've done previously. Our first option there would decide what we will be using next. If you've used AI with CDK4/6 inhibitor, probably a fulvestrant with a CDK4/6 inhibitor would be the choice here. If you've used only AI, then a second AI with CDK4/6 inhibitor or a fulvestrant with CDK4/6 inhibitors would be there. Always we'll be checking for the mutation testing for PIK3 pathway, and if they are wild type, then fulvestrant monotherapy or everolimus based combination could be used. If they are mutant, then fulvestrant with alpelisib can always be used for such patients. Next slide. Yes, sir. If premenopausal, there could be always be a where we concurrent treatment with ovarian suppression would be required to make them postmenopausal, either by ovarian suppression, oophorectomy, or ovarian ablation. when receiving endocrine therapy. Everolimus plus endocrine therapy is an alternative, but usually used in the second line and beyond treatment options. For those who have been treated with just AI initially, fulvestrant only, fulvestrant with CDK4/6 inhibitors always remains an option for such patients. Next slide. So fulvestrant plus palbociclib in patients who had endocrine therapy failure is, as we could see, the again objective response rates in this arm could be around 10% as compared to only fulvestrant where it was just 6%, and clinical benefit rate was 34% as compared to 19%. The OS in this population also was 34.9 months as compared to 28 months. Um, the PFS that could be seen with fulvestrant and CDK4/6 was 9.2 months as compared to the placebo with fulvestrant is 3.8 months. So high, though there were higher rates of neutropenia around 75 to 80%, but these patients did benefit with the combination of fulvestrant and palbociclib in the second line endocrine therapy setting. Next slide. Similar data of Monarch 2, abemaciclib with fulvestrant. The response rates here were impressive, up to 48%, and overall survival went up to 47% as compared to 37% the placebo arm. The median PFS also, as we could see, abemaciclib arm, it was 16.4 months as compared to fulvestrant only, where it was 9.3 months. Median in the Mona Lisa 3 arm also, the median OS was much longer for ribociclib arm versus placebo arm, 54 versus 42 months. So these drugs, even the first line endocrine therapy failure settings, would be beneficial when combined with a partner drug like fulvestrant, and all the 3 drugs have shown a fantastic responses and PFS and OS. Next slide. So again, based on the mutation that we have, PIK3 mutated, we could use alpelisib. For patients who have not been PIK3 mutated or wild type, then the alternatives could be everolimus plus AI or everolimus plus tamoxifen that could be used for such patients. Next slide. How do we choose the later lines therapy for such patients? Chemotherapy, antibody drug conjugates. Today we have sacituzumab govitecan as anti-TROP2 antibody drug conjugate for patients which are positive or 2 negative cancers after prior treatment with endocrine therapy and CDK4/6 inhibitors, and at least 2 lines of chemotherapy, including a taxane and in the neoadjuvant setting, which can be used for patients who are HR positive and HER2 negative, but HER2 low population, that is 1 plus and 2 plus. We have the drug TDX and trastuzumab deruxtecan. Fantastic drug, good responses, durable responses. Only side effect being development of interstitial pneumonia, need to be watched for that, and thrombocytopenia and pancytopenia, which occur again can with proper monitoring and consultation. All these things can be monitored. So this is one drug or which is available and can be used for such population. Next slide. Later lines of therapy again could be what we've not used earlier. So there are patients who been put on AIs and did not they became relapsed refractory, and then maybe just tamoxifen plus abemaciclib or tamoxifen monotherapy or abemaciclib monotherapy also did help for such patients. Sometimes some other drugs like megestrol acetate does work in such patients, especially in endometrial cancers where we which are HR positive, hormone receptor positive. We've used this drug for at least 5 to 6 months or 8 months of benefit for such patients. Next slide. So the special consideration could be given for BRCA mutated patients, where today we have an option of using PARP inhibitors for such patients. And there are newer drugs which will be coming, which will be targeted agents like maybe P10 inhibitors or something. Capivasertib is the drug now being approved after these second and third line therapies, which can be used and will soon enter the market. There are just like fulvestrant, there'll be other drugs like elacestrant, which will be available soon in the market for use in such patients after the second or third line therapy. And in the next 1 year or so, we'll see 3 or 4 new drugs in this hormone receptor HER2 negative patient population MBC, which could be used in the later lines of therapy for giving a durable PFS and a clinical benefit. Next slide. So we have a couple of options. I think in the first line and in the second line, depending on what was used earlier, AI plus CDK4/6 inhibitor or fulvestrant plus CDK4/6 inhibitor in the second line does remain our treatment of choice for all MBC HR positive HER2 negative patients, barring a few patients where they could have only one or two metastases here and there, where only a single agent could be preferred. All the three CDK4/6 available today, inhibitors available today, are at par, and real world evidence does suggest that all these can be used. There is no superiority established of one or the other, though the trials have mentioned that, but trials had different populations, different populations, endocrine. The later trials had more of endocrine sensitive population. The earlier trial with Palbo had a lot of endocrine resistant population, and early failures were seen. A lot of missing data was seen in the palbociclib arm, and all that could have possibly made the results poorer for Palbo in the Paloma trials. Every drug has a little different toxicity than the other, and so the patient population that we could use here would be a little different. GI toxicity people are abemaciclib to be avoided. Cardiac patients are ribo to be avoided. Neutropenic patients who had a problem and a lot of thrombocytopenia seen, anemia seen in palbo can be avoided, and other drugs could be interchangeably used for such patients. Second line treatment, we have alpelisib in PIK3 mutated patients, everolimus exemestane in mTOR, where we think that the mTOR pathway could be activated. Other drugs like elacestrant would be entering this, capivasertib would be entering this, what we say as segment where it could be used. And we have drugs for third line also in the endocrine population. Two subsequent lines of therapy failure would what we say as prompt us to use the chemotherapy in such patients to bring the endocrine sensitivity back in this population. Thank you for the patient listening. If you have any questions, we can take it.
Thank you, Dr. Tushar, for that wonderful, you went us through the very much elaborative overview of how the one approach has to be done for this metastatic breast cancer. So that was a wonderful talk, sir. That really makes everyone thinking now how one has to approach a patient, and then which particular, as you have rightly mentioned, one is there are certain points wherein one scores over another, but then the clinical trials are different because they had different set of populations while choosing this inhibitors. So we can take the questions and answers later on. So we'll have the second talk by Dr. Pratik, and then we can take the question and answer. So Dr. Pratik, sir, are you there? Should we?
Yes, yes.
Yeah. So
I'll
we
share
can.
the screen.
Yeah.
Yes. Is the screen visible?
Yes.
Okay. Yeah. So today we'll be talking about clinical evidence of palbociclib in metastatic breast cancer. As sir has already explained, the role of CDK4/6 in metastatic breast cancers that are HR positive and HER2 negative. Although there are slight differences as compared to the efficacy and toxicity of all the three CDK4/6 that is available, but most of the clinical oncologists, they have maximum experience with palbociclib as it was used much before the other two. So this is a selective inhibitor of cyclin-dependent kinases, that is 4 and 6. So Paloma 1, Paloma 2, and Paloma 3, out of which Paloma 1 was a phase 2 trial, whereas Paloma 2 and 3 were the phase 3 trials. These were the landmark trials that brought palbociclib into existence. And we will also be discussing the Indian data as well as the real world study, which whether to see whether they are in accordance with the Paloma trials or not. So coming to phase 2 Paloma-1 study, which was in the patients of postmenopausal who were 18 years and older, ER positive, HER2 negative, advanced breast cancer patients, where 1:1 randomization was done with a combination of palbociclib plus letrozole in the standard doses as compared to letrozole alone. The primary endpoint here was investigator-assessed PFS, whereas the secondary endpoints were objective response rate, clinical benefit, which gave a total of CR, complete responses, partial responses, and stable diseases for more than 24 weeks, duration of response, and overall survival. So as we can see, the graph was beautifully separating, giving a median PFS in the experimental arm of 20.2 months as compared to 10.2 months in the letrozole arm with a hazard ratio of 0.48. So there was a clear-cut difference that was seen with the use of palbociclib in combination with letrozole. Also, the objective response rate in the combination was 43% as compared to 33% in letrozole alone, with a clinical benefit of 81%. So all the patients who had CR plus PR plus stable disease were 81% as compared to only 58% with the letrozole group. So this was in the intention to treat population. So greater proportion of the patients in the combination had a good objective response to treatment and achieved a clinical benefit. Median duration of response was also higher in the combination, which was 20.3 months as compared to 11.1 months. And median overall survival was also higher, which was 37.5 months as compared to 33.3 months. If we look at the adverse events, obviously in the combination arm, grade 3 plus 4 side effects were significantly higher as compared to only letrozole, wherein neutropenia was the only significant grade 3 side effect, which was 48% as compared to only 1% in the only letrozole arm. All the other side effects were comparatively same. Neutropenia was well managed. So the conclusion to Paloma-1 was that it significantly did improve the PFS of patients in the combination arm, whereas the overall response rate and clinical benefit rates were also substantially improved, confirming the benefit. It did have side effects in accordance to neutropenia and leukopenia, but they were manageable. So palbociclib was hence approved by the FDA based upon the phase 3 trial, which included 666. That was the Paloma-2 trial. Again, in the same group of population that we had already seen in the last trial. So here the randomization was same. This was a phase 3 trial with the primary endpoint being investigator-assessed PFS and secondary endpoints, overall survival, objective response rate, and clinical benefit. So as you can see, the median PFS for the combination arm was 24.8 months as compared to 14.5 months in placebo plus letrozole with a hazard ratio of 0.58. This was a phase 3 data. So there was a significant improvement in the median PFS with the combination as compared to letrozole with placebo. So we can see the rate of objective response was also higher in the combination arm as quoted by the orange graph, which was 42.1% in comparison to 34.7% of a purple graph of letrozole with placebo alone. And the rate of clinical benefit was also significantly higher here. So greater proportion of patients in the combination group had clinical benefit rate to the treatment. Greater proportion of patients again had an objective response rate. So palbociclib plus letrozole combination had a good overall survival as well, which was 53.9 months as compared to 51.2 months. Here, the hazard ratio was 0.9, which was not very significant. So the OS was longer. Neutropenia was higher in combination, which was 80% as compared to 56%, although neutropenic fever was present in less than 3% of the population. Fatigue, nausea, and alopecia were also more common among the patients with the combination as compared to AI alone. OS data is not yet available for longer follow-up. So if we look at the subgroup analysis, we would be more interested in the Asian population. So in the study of phase 3 Paloma-2, if we look at the Asian population alone, the median PFS was still higher in the patients who received a combination, which was 25.7 months as compared to 13.9 months. So there was a doubling effect with a good hazard ratio of 0.49. So this was also consistent with the overall study population that the addition of palbociclib to letrozole did uh, improve the PFS in Asian populations as well. So for the patients who were previously treated with aromatase therapy, fulvestrant plus CDK4/6 is often chosen as the next line of therapy in these patients who progress on AI immunotherapy, as Sir has already discussed. So in the US FDA pooled analysis, among the patients who received CDK inhibitors plus placebo in combination with fulvestrant or second line or later systemic, 52% of them had died at the median follow-up of 45 months. The hazard ratio here was again 0.77. So now coming to the phase 3 Paloma 3 study data, which was fulvestrant and palbociclib. Here a 2:1 randomization was done with fulvestrant in the standard doses as compared to that of with palbociclib plus placebo plus fulvestrant alone. Here also the median PFS for palbociclib plus fulvestrant was good, more than double, that is 9.2 months as compared to 3.8 months with a hazard ratio of 0.42 in this trial. So again, significantly longer median PFS in the patients who have progressed on an AI. Median overall survival was numerically better for the combination as compared to single agent fulvestrant. The hazard ratio here was not that significant. Best overall response rate for the combination of fulvestrant plus palbociclib was 10.4% as compared to 6.3%. And also the rate of clinical benefit was better for the combination as compared to single agent fulvestrant. So greater proportion of patients in the combination arm had an objective response rate to treatment versus the placebo fulvestrant, and significantly greater proportion of patients in the combination had also a clinical benefit. So this is generally the standard of care for the patients who have progressed on an earlier AI. Neutropenia is obviously higher because of the use of palbociclib, which is 78.8% versus 3.5% as fulvestrant does not cause any neutropenia and fatigue. However, discontinuation rates were very low on both the study arms because they were easily manageable with the lower doses of palbociclib. So real world studies, if we look at them, the sensitivity and effectiveness of palbociclib plus endocrine therapy in the subgroup of population that is in discussion. So here the primary endpoint was to evaluate the PFS as that of the same. So with the drug combination of palbociclib and letrozole, in the first line, the median PFS was 16 months. In the second line, it was 12.6 months, where in the patients with more than 3 lines was 8.3 months. And thus, as in the combination of palbociclib and fulvestrant in the first month, it was 17.6 months. In the second line, it was 14.1 months, and more than 3 lines was 5 months. So median PFS time of the patient who had received the combination with either both letrozole or fulvestrant as a first line was longer than the patient who have received it second line or beyond. So right now, as per the standard of line therapy for any patient who's a metastatic HR positive, HER2 negative, a combination is definitely preferred with the CDK4/6, preferably palbociclib with either AI or fulvestrant, depending upon the patient toxicity profile. So to conclude that the combination therapy needs to be put. So to conclude, palbociclib did significantly improve progression-free survival and clinical benefit rate when added to letrozole in postmenopausal women as an initial endocrine-based therapy. And it did prolong PFS and OS when added with fulvestrant in the women with same who have progressed on previous endocrine therapy on single agent. Also, the available data that we have from the real life experience confirm the good performance of palbociclib in unselected, heavily pretreated populations. So the combination is the standard of line therapy for these patients now. Also in the real world study, which compares the newer users of palbociclib fulvestrant to a historical comparator group of only fulvestrant monotherapy, safety events commonly associated with palbociclib use were mostly similar to those identified in the randomized trial that was more in favor of more neutropenia with the combination as compared to no neutropenia in fulvestrant, although fatigue rates were equal. There is a trial from multi-center in India, which was a real-world evidence with palbociclib in hormone-positive, HER2-negative metastatic breast cancer in Indian population. These patients were taken from Feb 2017 to May 2020. Here, also in the first line, the combination was used as standard, and in the second line, fulvestrant in the standard doses with the combination of palbociclib was used. Here, the endpoints were PFS, progression-free survival. So as we can see, the median PFS for the combination was 20.2 months, which is in accordance with the standard trials of Paloma that we have seen. And also as per the Paloma 3 trial, the combination of palbociclib plus fulvestrant was 12 months. Objective response rates were also good, which was 80% for the first line, as well as 47.9% for the fulvestrant combination with palbociclib. So overall, this is the largest real-world data on the use of palbociclib in Indian population, suggesting an effectiveness similar to the previously published real-world evidence, and is the standard of care in the first as well as second-line treatment of these patients. So again, these are the trials that give us and show us the efficacy and safety of palbociclib. Again, they are in accordance with the trial data that we have available from world over. These are the trials that were performed in India. So in this trial as well, where total of 24 patients were included, the median PFS was 18 months and the median OS has not yet reached. The 1-year PFS and OS was 73 versus 89% respectively. So to conclude again, with this trial also, letrozole plus palbociclib was effective and with manageable toxicity as the first-line treatment for HR positive and HER2 negative advanced breast cancers. Thank you.
Thank you, Dr. Pratik sir, for that wonderful talk. It was really exciting to hear from you about all the trials of palbociclib. Of course, the real world evidence that you showed was really exciting. So just one question, sir, from my side. When we talk about the overall survival, wherein in most of the studies, not only these studies, it says that it is not reached. Any probable reason for such a occurrence? Is it statistically related, or is it the follow-up has to be more for such patients, or some selection criteria is an factor?
So I think the follow-up is a major problem, as most of the Indian patients, they do not follow up at a single center when they are, because the overall survival for these patients is in any case more than 2 years. But in most of the situations, these people tend to travel here and there and then are lost to follow up. So the data that is collected is for very less amount of people. So the statistical analysis also becomes difficult.
So, sir, wonderful talk. We really enjoyed hearing you after a long time. If I suppose most of the trials and everything, you have taken it so brilliantly that I couldn't we have any questions in the chat boxes. But yes, if at all they come, we can always post them to you. So thank you, sir, for joining us for this talk. And I hand over it to Geeta. Geeta, you can convey the word of thanks, and then we can. So we are on time, sir. Actually, we started on time and we are ending on time. That was really,
Yes,
yeah.
yes,
Yes, Geeta,
yes.
over to you.
Yeah, sir. I think so. Dr. Pratik, Tushar sir has left. I think he was in hurry, and the connection also was not proper for the Dr. Tushar Patil. But Dr. Pratik sir, thank you so much for joining this session, and you are taking your time from your daily schedule. And we are very thankful you join and give us a meaningful knowledge and about the all over the current scenarios on the palbociclib and your perspective. Thank you so much, sir. And again, thank you so much for the attendees for taking your time from your daily schedule and joining this session. And any doubt and any questions are there, please let us know. So we convey the all the questions to the sir, and we will get back to you as soon as possible.
Geeta, thank you all. Thank you, Rajesh ji. Thank you all the backend teams. And thank you.
Dr. Kamble, for you also to take your valuable time from your